Great colleagues, and welcome to today's session. It is just got to the top of the hour and we'll get started. My name is Francis Ochen from the African Society for Laboratory Medicine. I'll be moderating the session for today. Our session will run for 1 hour and we have language interpretation services. Please pick either English, French, or Portuguese, depending on the language of your choice. We will also encourage that you join the discussion through the chat and Q&A, and that's the only alternative way for you to join our discussion today. As you may be aware, the African region remains vulnerable to infectious diseases, and our great environment does not only favor beneficial crop, animal husbandry, and unaided human survival, but it also favors the multiplication of pathogenic microbes. And therefore, our healthcare system and diagnostic network capacity really needs to be most resourced. It should be the most efficient. It should also be the most effective and the most innovative, among other things, to help us deal with these infectious diseases if we are to optimally address some of those challenges that face us. And considerations for testing multiple diseases on the same platform or testing multiple analytes using the same samples simultaneously then becomes very key when dealing with this huge burden that faces our continent. So in today's session, we have the privilege to hear from Zambia on the work that they're doing to enhance clinical diagnostic capacity for infectious diseases through the National Multi-pathogen Diagnostic Program that they are running. The team will also highlight some of the current focus, their key considerations, and the emerging opportunities from the intervention that they are currently implementing. And colleagues, to take us through this, the Zambian team led by their speaker is going to be Dr. Suilanji. That name is difficult, but it is easy for Suilanji. So Dr. Suilanji Silwamba, and Dr. Suilanji is actually a research fellow working with the Enteric Disease and Vaccines Department of the Center for Infectious Diseases Research in Zambia. He also serves as the coordinator for the National Multi-pathogen Diagnostic Program, providing technical oversight in the implementation of the National Multi-pathogen Program in Zambia. So Dr. Suilanji, let me hand it over to you to take it on from here.
All right, thank you. Thank you. So as introduced, my name is Dr. Suilanji Silwamba. You actually did a good job there, Francis. So I'll be taking you through the National Multi-pathogen Diagnostic Program, also known as NMPDP, here in Zambia, which is focused on supporting patient-centered care through strengthening microbiology and molecular biology techniques in Zambia. So a brief background. So sub-Saharan Africa is vulnerable to infectious disease epidemics, usually due to favorable climate and ecological conditions for vectors and pathogens, and also high animal and human interactions enhance the spread of infectious diseases. In low-income countries like ours, the low capacity to manage epidemics is due to inadequate resources for early detection, identification, and prompt response. So here in Zambia, based on the National Health Strategic Plan, it notes that only 55% of second-level hospitals and 23% of third-level and above hospitals are able to perform culture and sensitivity tests, which basically leads clinicians, as you know, to treat empirically, and which contributes to poor treatment outcomes and antimicrobial resistance. So what's the approach that we are taking? So the CDC-funded CIDES Trails project is supporting our Ministry of Health to establish this program, and our initial focus is on respiratory conditions and conditions affecting people living with HIV, such as CNS and STI infections. The program's overall aim, is to improve diagnostic capacity and scale up surveillance systems to improve patient management and outcomes using open PCR platforms. So I thought I should note some key definitions so that people don't get confused in terms of terminologies. Terms such as multiplex testing, which refers to diagnostic approaches that simultaneously detect multiple pathogens from a single specimen using multiplex PCR platforms, like what we're doing in this program, and multi-disease testing, which basically means a broader testing strategy that screens for multiple diseases through a combination of tests conducted together. So basically the distinction is that this program is a syndromic-based multi-pathogen diagnostic approach to determine etiology of syndromes such as respiratory distress, CNS, STI, infections, as well as febrile illness. And the rationale behind this is that this approach is resource efficient, improves diagnostic accuracy, and has faster patient management. So what are the current diagnostic limitations and opportunities for the NMPDP program? So there are established programs in the country for respiratory, STIs, and CNS. However, the limitations are that these programs focus remains limited to either TB, HIV, syphilis, SARS-CoV-2, excluding many high-burden infections, especially among vulnerable populations like people living with HIV. Another limitation is that they mainly use closed PCR systems, which restricts the detection of pathogens outside the manufacturer's scope, such as those like the Panthers and Gene Experts. And this brings the opportunity of this program where we are able now to test for other pathogens causing diseases, as well as co-infections for respiratory. We're able to screen for virus pathogens, whether viral, bacterial, or fungi. For example, influenza H1N1, influenza B, pneumocystis, or streptococcus pneumoniae. For STI, we can go further to screen for outside HIV and syphilis, CTNG, human papillomavirus, hepatitis B, herpes. And as you know, for CNS, most countries, the diagnosis is limited to culture. And the opportunity here of the program is that there is now capacity for screening for viral pathogens and others that are very difficult to culture. So just to reiterate the justification of this program, firstly is to improve patient outcomes by implementing a broader diagnostic coverage, especially for opportunistic infections in people living with HIV, enabling earlier detection and targeted treatment, and also expanding facility test profiles by implementing detection of other pathogens causing disease. For example, if a patient comes in and the TB gene expert negative, what else could be causing that clinical presentation? And also strengthening public health response by expanding the diagnostic capacity, which supports timely surveillance, outbreak detection, and evidence-based intervention. So the NMPDP has four main objectives. And the first one is to strengthen microbiology diagnostic capacity in public health laboratories by increasing staff complement and competency, supplying reagents where needed, provision of equipment, and also lab infrastructure. Secondly is to set up open PCR testing platforms for the detection of multiple pathogens causing diseases, not limited to only respiratory, like I mentioned, but also STI and neurological infection. And thirdly, to establish an algorithm for microbiology, molecular testing, and pathogen genomic sequencing. And lastly, to strengthen public health surveillance systems for infectious diseases in Zambia. So this is just a map of Zambia. As you can see, there are 10 provinces, and the approach being taken by this program is that we have been setting up open PCR platforms in at least each of the provinces. Initially, what would happen during an outbreak response is that there was centralized testing, and we had only two provinces that had capacity, which was Lusaka and Copperbelt. So you can imagine that samples would have to travel, let's say, from the northern region all the way to the southern region to get testing. And for outbreak responses, that's time is obviously a big factor. So what this program aims to do is have decentralized testing, especially for the bordering provinces, so that they have built capacity to do what the other provinces have initially been doing, Copperbelt and Osaka. So these are the facilities currently that are being supported by this program. And so far, we've activated 6 provinces which are actively testing and implementing the program. So those are the ones that are highlighted with the asterisks and bolded. So in terms of the laboratory network and tier functions, the approach is that we are using spoke and hub model. And I must mention that every tier in this network is able to collect samples, but basically the spoke sites are facilities, primary health facilities that are able to collect samples and refer them to the hub laboratories. And these facilities have limited or no microbiology. The hub laboratories can receive samples from the spoke sites and courier these samples to the OpenPCR labs, but they can also perform microbiology testing. At the OpenPCR labs, these are testing hub sites with both microbiology and OpenPCR capacity. And these then courier samples to our genomic sequencing facilities. So I must mention the genomic sequencing sites can only sequence samples based on the criteria from our Zambia Genomics Consortium and the National Genomic Strategy. As you know, sequencing is very expensive, so not every sample can be sequenced. In terms of the clinical workflow, so in a nutshell, clinicians will initiate the diagnostic process. The program case investigation forms are or will be used to capture patient data in real time and also transcribed into digital records. And for notifiable diseases, clinicians will ensure that the case definition is met before samples are collected for laboratory testing. So this is just a picture of the OpenPCR platform that we're currently using. We're using QS5s, QuantStudio 5s, and QuantStudio 7. And this is a picture that was taken at one of the facilities that has been activated so far. So in terms of primary sample specimen types, these are the specimen types that can being used currently in the program, and that these are not strictly what can be used, but these are the primary ones. As you know, as long as you are able to extract and get nucleic acid from any sample type, and you have your specific master mix that want to use, the OpenPCR platform is quite open to detect what you want. But however, for respiratory, our primary samples are nasopharyngeal swabs, dot swabs, sputum, alveolar lavage, tracheal aspirates, pleural fluid. For CNS, we'll be looking into cerebrospinal fluid, fast aspirates, and blood cultures. And for genitourinary infections, swabs, urine, and scrapings. So what does the specimen workflow look like? So as a proxy, I'll use the respiratory infections. So clinicians, trained clinicians will be the ones responsible for meeting the case definition and also collecting samples. And this is so that we maintain sample integrity. They should also know how to transport the samples at 2 to 8 to the laboratory within 8 hours of collection. And we're using established systems already in these facilities, and we're not changing this to be a parallel system. So that helps us in terms of sustainability. So once the sample reaches the laboratory, total nucleic acid extraction is performed. At the moment, we're using Kaijin kits. You can also use either a manual automated platform such as the Kingfisher or EasyMag. Once done, master mix preparation is done in a clean room. And again, there are multiple options here, which is the advantage of an open PCR platform that you can use a commercial validated multiplex kit. At the moment, we're using a respiratory panel. You can use also a commercial singleplex kit. We had initially used one for monkeypox, and as well have do a customizable in-house assay, of course, subject to validation. If you're doing an in-house assay, you'd want to validate your assay before you generate results. And these samples are then run on an open PCR instrument like the QS5 in our settings and the QS7 Flex. Positive pathogen results are determined using a cyclothreshold cutoff of 33. Our instruments are directly connected to an LIS system. So these results are then transferred to an LIS system, which can be accessed by clinicians so that they can promptly manage their patients and on dashboards for surveillance. So I thought I'll just put up this slide. There are multiple alternatives from the molecular multiplex platforms, such as the QIAstat or CSF96, and also applied biosystems and life technologies. They do also have other platforms, so we're not really restricted to the Quant Studios as in our setting. So I did bring up a dashboard. So we're also developing a dashboard that can be used, a national dashboard that can be used for surveillance purposes. And our thoughts are that this can be filtered by location, testing facility, and also by pathogen of interest or co-infection. And we're also planning to integrate clinical metadata with the laboratory results such as AIDS, sex, and HIV status. Because the important thing is laboratory results are just laboratory results. But there's more power in that if you have metadata tied to these results. In case we do have a pathogen of interest, maybe an outbreak or in epidemic potential pathogen, you'd want to know where this is coming from and how to track it. So in terms of the respiratory pathogen panel that we're currently using, this is just a snapshot of the pathogens we're able to detect in one specimen, which is an array of viral, bacterial, as well as fungal. And these are about 30 pathogens that we're able to do in a single run. For genomic sequencing, like I earlier mentioned, these are sequencing laboratories that will be the highest tier of the network. And the criteria for what samples go for sequencing is based on the National Genomic Strategic Plan and our Zambia Genomics Consortium. Like I did mention, sequencing is very expensive. And this is just a way of mitigating those costs. And the aim here is to identify and understand the genetic makeup of pathogens to aid pathogen public health, and also provide information regarding tracking and controlling disease outbreaks. So like I mentioned, one of the main focuses of this program is to see how many patients are actually benefiting from this program that are living with HIV. So this is just a snapshot of some of the demographics. Like I said, the data showing those that are benefiting from the program. I should also just mention a disclaimer: the dashes there don't mean that the prevalence of HIV patients is zero. It's just that we have not been able to collect this data yet. So one of our limitations or challenges so far is that the clinical side of this health, some of these health facilities, or not all, have their own information system. The laboratory also has its own information system. But we're working on mitigating this by bridging the gap and having the two information systems speak to each other so that we can in real time have this information. But I can say confidently that above approximately 9% of the patients that are being serviced by this program are benefiting from this test. Thank you. So in terms of the trends and for respiratory pathogen detection, so the benefit of having these platforms connected to our laboratory information system is that we're able to look at epic curves. We do know that this is not really a true reflection of seasonality as we've only been running for 1 year. But however, we're able to at least see what we've been detecting in the last year. So as you can see, Streptococcus pneumoniae has been quite persistent throughout the time of the program launch, and actually has been increasing the last few months. RSV is a pathogen that has been emerging quite high also as we move into our cold season. At some point, as you can see, influenza B, we had some sort of outbreak between July to end of September, entering October, but however, that has been controlled. And then we do see some sporadic positivity between in Klebsiella pneumoniae and human rhinovirus. So what are the implementation costs to consider for those countries trying to embark such an approach? So I must mention as a disclaimer, the cost effectiveness analysis is still ongoing as we're still in the implementation phase, but we are considering both the service provider and also the patient perspective. But however, for cost saving, where we feel that this program is saving on cost is on time to diagnose. So you can imagine bacterial culture usually takes 5 to 7 days to come out, and our turnaround time for this program is about 24 to 48 hours, which also would mean that shortened hospital stay for patients, and also reduced empirical treatment when you do have accurate diagnosis of what is affecting these patients, and reducing on misuse of antibiotics, and also shortened human resource and time allocation, both on the clinical side, as you know, clinicians would have to tend to a patient who's staying longer in the hospital, and also on the laboratory side, a lab tech does not have to spend too much time running one particular sample. Then other cost drivers are in the implementation phase of this approach. Infrastructure is one of the cost drivers. Most of these facilities that we went into implementation did not have extraction, clean, and amplification rooms. As you know, for molecular techniques, these are important rooms to have. They help in reducing contamination, and also providing knowing that you are providing accurate results and these are not coming from the environment. Also open PCR platform, the cost of the actual platform itself, and also maintenance of these platforms, as we are going to at least 1 year since we started this program. There's some instruments that will now need some maintenance. As well as stakeholders engagement and sensitization meetings. As you can imagine that this is something that's currently new. So a lot of orientation and sensitization is needed for demand creation. We don't want these instruments to be white elephants in these facilities. And also strengthening existing systems such as sample courier systems. So for patient-centered care, you want a system that meets on-demand courier services, especially for those in the spoke sites, and not those time-bound, not those fixed time courier systems where it's only once or twice a week. We need constant courier of the samples to the open PCR laboratories so that we can have good samples that have met the integrity test for accurate testing and patient management. So in terms of implementation considerations, like I alluded to earlier when explaining specimen workflow, personnel competence is important, both on the clinical and laboratory side. On the clinical side, we need competent clinicians that are able to identify the case definition for those that meet the criteria to go into for testing, and also sample collection. You want high standard samples being collected and sent to the laboratories at the correct temperatures and time. For the laboratory side, we also need competent lab staff, at least those that have some sort of molecular experience. We say this because what we've noticed is that even if they're using closed systems, they're quite personnel of these caliber are quite easy to train because they do understand the technology, and it takes about a week or two to have them up and running. For the facility side, you need to check the availability of auxiliary equipment to support the assays, such as pipettes, centrifuges, freezers, and bioseptic cabinets. These are quite crucial, and you need to procure these if the facility does not have. And also, like I mentioned, laboratory infrastructure such as extraction, clean, and amplification rooms. Um, just to say, for these, you don't need to build a lab from scratch. An open room that can be divided using prefabs is something that can be done. And you do see quite a number of good modern labs doing this now. And also laboratory information systems are also crucial for results return. So we do have a lot of complaints from clinicians saying samples do take long to get back, as sample results do take long to get back to them. So just so that we can meet good turnaround time, clinicians should be able to get results as soon as they're being validated for them to manage their patients. So what has been the impact of the open PCR molecular diagnostic so far? So enhanced disease management for people living with HIV through advanced diagnostic capabilities, and also accurate detection and tracking of diverse pathogens, including hard to culture and slow growing organisms, and also rapid identification of opportunistic infections such as pneumocystis and viral core infections, enabling timely interventions. So we've had situations where a patient is immunocompromised, and we have been able to identify pneumocystis in these patients, and we've had some good feedback from clinicians saying that this was very helpful for their patient management, and also improved patient outcomes via early diagnosis and prompt treatment initiation, and also decreased the use of unnecessary treatments, prompting targeted effective care. So what have been the anticipated challenges and limitations? So we do, as I mentioned earlier, this is a program that's being supported by CDC, and we are working on a sustainability plan because we don't see ourselves in these programs in the long haul. Of course, we need to hand over to our Ministry of Health. And one of the things we've seen in the past is sustained reagent and equipment supply. So as we are still working on mitigating these challenges to sustainability on our sustainability plan, it's still an anticipated challenge, just in case we do fall into that particular trap. And also ensuring consistent staff training across tiers. So we've been working with CLSI just so that we can have standardized SOPs and protocols, and also now embarking into external quality assurance processes just for our tests so that we know that in the long haul, what we are, the results we're generating are up to standards. And also data management integration with clinical AI systems. Smart care, like I alluded earlier, a challenge has been to marry both clinical and laboratory results. But we are working towards mitigating this challenge because, as I mentioned earlier, metadata, not just metadata, but clinical metadata to get laboratory results gives you a full picture of what's happening in our population. So what have been the accomplishments so far from this program? So we managed to establish a national framework for the multi-pathogen testing to support data-driven policy. And we facilitated the development of the National Genomic Strategic Plan, which was launched in February this year, and also enabled real-time tracking of seasonal respiratory pathogens, improving outbreak response. And I must mention one of our achievements is that during last year's 2024 flu season, the Open PCR platforms confirmed influenza A pandemic H1N1 as the main cause, ruling out COVID-19 resurgence, which meant accurate pathogen identification and improved patient care and reduced use of unnecessary COVID-19 treatments. As you know, treatments of COVID-19 and influenza are quite different and sometimes even fatal. You can't use steroids on a patient that has been infected with influenza. And lastly, enhance resource allocation and cost effectiveness through targeted diagnostics. So this was my last slide. I would like to acknowledge all our stakeholders and partners in supporting this program so far. Thank you. I'm now open to questions.
Thank you. Thank you very much, Dr. Sui and team, for this excellent presentation, really sharing with us the work that's happening down there in Zambia, covering the justification for this multi-pathogen testing, but also the sample sites that you're currently dealing with. We appreciate that there are sites that you need to work with. Kindly confirm that you can hear me.
Yes, I can hear you.
Okay, sorry. Yeah, so and then going through the respiratory panels with over 20 pathogens and also looking at both the commercial kits and also those that are built locally, of course, with validation considerations, which is a good thing to do. So we have already some few questions that are coming through, and I'll start with one that came from an anonymous presenter. And I mean, this is related to the aspect of, are we treating our patients only based on the identity of the pathogens? Or are we doing reflex testing? When we identify them through our PCR, we then run cultures to get the susceptibility profile for each of those pathogens. Or are you also able to do genotypic DST to be able to provide antibiotics that are going to be effective in the treating of those pathogens that you're identifying?
Thank you, Chair. Should I go ahead and answer that question?
Please do. Thank you.
All right. Thank you. Thank you so much for that question. And it's a very important question, especially for the bacterial pathogen. So at the moment, we're actually working with the microbiology labs to ensure that 2 swabs are actually taken, one that goes to for culture and another one for the PCR platforms. Like I did mention, Streptococcus pneumoniae seems to be the one that's prevailing. And we do have our sequencing laboratories. So we haven't yet done our whole genome sequencing, but it's something that we have planned to do in the near future, so that we can have a full picture from virulence factors as well as antimicrobial resistance of these, so that we are able to bring that graph to almost zero, because clearly our interventions at the moment don't seem to be working as well, so well so far. But that's a very important question, and it's something that we're looking deeply into. Thank you.
Great. And again, just to add on to that question, there is a question that relates to the sample collection. And so if you could just explain to us the current pathway that you're taking in terms of, do clinicians just make random requests for a particular test, and then the lab makes a decision on whether this should go into the multi-pathogen testing pathway, or we can go into the single disease testing pathway? So how is this playing out? If there is an infection in a certain site suspected, is it the clinicians that are making that decision to go the multi-pathogen pathway, or it gets to the lab and then the lab provides the advice and then we get the samples coming through? So how is that playing out?
Thank you for that question. So at the moment, it's at the clinician's discretion. So there is an algorithm that they have set up. Um, and they're the ones who determine whether this goes for the open PCR testing. So the algorithm, for example, is basically first the samples go for, let's say, microbiology or gene expert. If they are negative, and then the decision is then made to say what else could be causing this infection. So we don't want to, like I mentioned, to have parallel systems that we're integrating ourselves in already existing systems that are happening in these health facilities. So I hope that answers your question in a nutshell. Otherwise, if others on the panel are able to contribute, I'll be open to that as well. Thank you.
Yes, I'll get the panel in at some point. And so again, just to move it a little further around still the same area on how things are playing out, especially the sample handling. And I know that you indicated probably about 7, 8 sites where this is happening. You can correct me with the specific numbers. And so what is the scale-up plan? So do we see us moving from this, maybe these are tertiary sites in terms of our healthcare network and structuring? Do we see us going below this first level of sites that we've started with? And is it horizontally only sites at the same level, or we believe that we can even go to sites at lower levels if some of the considerations that you've provided here are provided for?
Thank you for that question. So at the moment, these are tertiary health facilities because they have the most of the infrastructure already in place. So far we've done implemented 6 facilities, we're remaining with four more. I'd like to say that at least we are almost ready to go. So maybe the next month or two, these would have been activated. And yes, there is a plan to go down to the primary health facilities, or can I say even the small districts, especially those in the border towns, because those are the ones that are prone to unknown outbreaks per se. So in the future, hopefully near future, we plan to cascade down to those facilities, and also cascade to also testing other syndromes outside respiratory. I submit.
Thank you. Thank you very much, Dr. Sui. Let's move it to, I know you brought up the aspect of the cutoff CT value, the threshold of 33. And that seems quite high, meaning you're really picking almost every trace of the pathogen in the sample. And so just clarify for us, because we know that some of the respiratory pathogens can be there without necessarily causing trouble if the immune system is competent. But because somebody is coming to the facility with a symptom of some sorts in the respiratory tract, how is the interpretation of results happening? Because you may pick 3, 4 agents, and because of your very low CT, your very high CT value, which means you're picking very low level bacterial load or viral load for that matter. So how is the interpretation of the results happening so that then we are not treating things that probably are not our problems?
Thank you. Thank you. You're asking very pertinent questions today, actually, and questions that we've been getting quite a lot. So, firstly, on the CT cutoff, we actually thought it was quite low, but we're working on optimizing that. As you know, most literature, I guess, in research, 35 is the cutoff. But we're also trying to embed the genomic sequencing side of things because they feel obviously 35 is too high to get something to sequence, and also now pleasing the clinicians. So for 33, what our ID physicians have been doing is using also clinical, can I say, clinical presentation of symptoms to help them aid in treatment management, because you can imagine we're also getting co-infections and not just mono infections. So what they've been doing is marrying all the information that they get to make a decision on treatment. Because, like you mentioned, some positives might not actually be viable. Could be something that's been was there but is now being cleared. So as a scientist, I think that's my level of understanding so far. But I'll ask others on the panel to contribute to where they feel I have left out. Thank you.
Powell or Michelle, if you have any addition to make, kindly jump in.
Hi. So thanks.
Hi,
I think pertinent question. So we are still, I think, debating the challenge that I think has been raised is once you multiplex and get multiple targets, which are all pathogenic, the question really is to be careful around things such as polypharmacy, as well as trying to find out what is the really causal agent. And so this is why I think Suiranji raised the comment that we are working to integrate and have access to the clinical data so that we can start working on algorithms that can refine the way the results are utilized as well as the way they are reported. So that, as you said, we are not reporting just mere detection of a speck of nucleic acid, but it's something that can be related to a clinical outcome. So we are aware of the challenge as it is, and are working with clinicians and statisticians to be able to do this. Part of some of the work that we did on before we came to this multi-pathogen diagnostic was on enteric disease using a multiplex panel. And what we developed there was a way in which we can do what we are calling an attributable fraction. But then again, these are evolving questions and things that I think on one hand, they seem to be a problem, but I think are an opportunity for us to be able to respond to and learn how we can manage. Over.
Thank you, Michelle, for that addition. Quite helpful. Let me take this question from Elvis, and I will read it verbatim so that I do not dilute the content. You may have already seen it, Siwa, but I mean Siwi. So what is the current sequencing rate for this national multi-pathogen disease program?
Elvis is silly. He's part of the...
Is part of... Okay, yeah, so So yes, so he is asking, and probably for the benefit of our other participants here. So what is our current sequencing rate for this multi-disease testing program? And also, how is the result feedback mechanism working with the NGS labs in the country? So you guys probably have a context to this question, and just for the benefit of our participants.
Thank you for that. So like I did mention that the National Genomic Strategic Plan was launched in February this year. So far what we've done on our end is ship most of these samples to the reference laboratory, which is the NMPDP. And based on the genomics consortium, they're then going to identify which pathogens are going to be sequenced. So this hasn't yet happened, but I do understand there's a fairly good interest in the RSV positivity from most of the facilities that have been seeing this positivity rates that have been showing you that it's been coming high. Because as you know, RSV is quite detrimental or seen in infants and children, but we're seeing a large number of now adults picking up this. So I think we have some meetings in the near future to basically discuss the frequency of sequencing of some of these pathogens. So at the moment, there are 2 reference laboratories, but there are a number of sequencing laboratories that are part of the Genomics Consortium. And the plan is basically to disaggregate and distribute some of these samples across these laboratories. Thank you.
Okay, so thank you. Now let's get to, Michelle, you want to say something additional to that?
Yeah, just quickly to say that we are fortunate, if you like, to have also a genomic surveillance framework that we have, which builds on this. And this identifies both private and government sequencing capacity. So at the moment, given the pathogens that we have tested, the RSV are the ones that are earmarked to begin the sequencing. But we are working with the sequencing labs, as Suiranji has said, to ensure that then, depending on either the capacity for analysis for bioinformatics and specialization, those then we can be able to send samples to them for sequencing so that we can have a quick turnaround. And this is something I think that we are discussing in the Genomics Consortium Technical Working Group. Over.
Thank you. Now let's get to the panels. I know you spoke about having the commercial panels that are out there, but also you can do the customization locally based on probably your disease epidemiology, and you come up with a master mix or a concoction, for lack of a better word, that speaks to the disease patterns in your country, and also depending on the site that you're going to be dealing with. And so in your experience implementing this, are you, even with the commercial panels, are you selecting panels that relate to the disease patterns and epidemiology in Zambia? And if yes, what are some of those that you're really considering as your first priority? And are you also going to try and do the customization for locally generated panels?
Thank you, Francis. I feel like you have been sitting in some of our stakeholders' meetings. So yes, so I do agree with you. 30 pathogens is quite a lot, and I can mention that there are some pathogens we have not detected at all. So the plan moving forward is to do a full 1 year like I mentioned, we only started in July, and we're left with a few more months to July, August, so that we can have a full picture of what is really circulating in our population, and then narrow it down together with clinicians, of course, not just the laboratory staff and other partners, to prioritize the pathogens that we feel are the ones that are really important to us. This will also bring down the costs, of course, of of the kits and also of the test. Um, so we are still yet to agree on whether we go through the commercial way of just telling the manufacturer to say, can you just make me this panel? This is what I'm interested in. We then do some verification, validation tests, and we move on that way, or we basically make our own in-house assay from there and move forward. But that was a very good question to bring up and a good discussion point. Thank you.
Thank you, Sui. And just again from a colleague, I'll use the name Ruto. So from Ruto, and Ruto is asking whether, given this development and your learning, if you see a future in Zambia where you will be checking out the conventional microbiology analysis, microscopy, basic culture, and sensitivity, do you see this getting out, or you're going to continue doing the complementary work from this genotypic approach and then the phenotypic approach that microbiology provides us with?
Thank you for that question. And I think a lot of people ask those questions that these other platforms are coming to take over. And I think the answer is no. I think the traditional methods are still very important, especially for morphological and biochemical analysis, as well as genomic analysis. So for bacteria, you can't sequence without a colony. You can't do AST, and I think you alluded to this. You need sometimes you do need live viable material to answer some questions. So I think working together with all these other techniques is something we can move on forward with, and having now AI and these information systems, we can have something that can give an aggregate picture of all the important information from all the techniques, which gives you basically a fuller picture of what's going on in these various populations. I submit.
Thank you, Sui. And just as we get towards the end, we will keep the questions coming. And also thank you to the team from Zambia. They're their colleagues who are already helping with responding to some of the questions in the chat, in the Q&A space, and chat as well. So just to reiterate again, another question, and this relates to the first question that we were asking around the scale-up plan. So Albert is again asking, is there a plan for decentralizing the multiplexing program in the country, and maybe with some timelines, or you want to first use your first year of learning and then that can inform your scale-up plan?
Yes, so we're using a phased approach with almost everything so that we don't do too many things and fall apart. So even when we're doing our activation of these facilities, first we are narrowing down to just having the facilities test just the samples that are being collected by that initial facility. And then we do a scale up when they now introduce the spoke sites around that facility and then the province. So as we do that, we then and we're comfortable that the facility is able to stand on its own. We then move on to the next phase, and like you said, there are plans of now moving down to the lower level facilities or districts. Thank you.
Thank you very much. And I do not know if Powell, I would give you maybe a minute just to to make some general comments related to the session today. I know you're online. If you could just kindly make some general comments related to the session today, the scale-up plan, your investment portfolio in terms of what it is that you've covered this far, and some of the experiences that you've gone through, the multi-stakeholders engagement and others that you've gone through in getting us to the far we've come with this multi-pathogen testing in Zambia.
Thank you so much, Francis, for the opportunity, and just thank you so much to the team in Zambia. So, like you've indicated, and also the submission in the comment, this work really cannot be achieved if teams in countries are working in silos. So having the strong and resilient technical working group is very key, very key. You need all the stakeholders to be on board, and that's what we did in Zambia. So when this was conceptualized, and this is what would recommend to other countries that would want to take this on board, is to ensure that all the stakeholders are involved, from the funders, from the players, including the implementers themselves, the laboratories. There is a lot of work in terms of putting documents together. So ourselves as Zambia, we started by developing the implementation framework. So we have a framework in place, and through ASLM, if there are colleagues within other countries that would want that framework, is available on the Ministry of Health website. But we are happy also to just share that, so that you do not reinvent the wheel. But also, as you are implementing, training is key from the clinical side. So we have a team of excellent ID physicians that are creating demand, and they are training the clinical teams on how to use these results. From the questions, we see that it may not be easy if you find multiple pathogens from one sample. How do you handle that? So having a strong clinical team and infectious disease experts is key also. It's a key pillar. I think that's what I would say. Much of the things, Swilanji, and also the questions that have come through, they've been addressed. Thank you so much, Francis. And
Thank you, Powell. And I certainly will need a copy of the implementation framework, and we will share that alongside the slides that will be going out to participants that have been with us here and others who will be accessing those materials online. And so we have just barely a minute to wind it up. And so, Dr. Sui, let me hand it over to you to just give us your closing remarks. But as you do that, you could also just highlight if you've got any regulatory challenges in rolling out this, because there is a question coming in from Mitch, and Mitch is really asking if, from a regulatory point of view, if there are some of the challenges that you may have faced in rolling out this very interesting initiative. So over to you for your closing remarks, but also dealing with that if you have any comment to make.
Thank you. So firstly, to answer the question, so we've had multiple stakeholders engagement from different stakeholders, as you can see, in country, and also collaborators, including our regulatory bodies in the country. So we haven't had any bad feedback. And we're still working closely with them just to ensure that we are meeting all the ethical considerations. I hope that answers your question, and that we do also give any reports of any excursion, but so far we have not had any. In terms of closing remarks, I'd just like to thank everybody on the call for having given me this opportunity to just showcase our program as we continue to implement it in our country. And we're always hoping to do better, and hoping to get more feedback from others to see how best we can improve, and also moving forward, how best we can sustain the program for the long haul. I submit. Thank you. Back to you, Chair.
Thank you. Thank you very much, Dr. Suilanji Silwamba and the team from Zambia. Excellent sharing there. Of course, there is that bi-directional learning, but we've learned a lot from the Zambia team today with regard to rolling out this multi-pathogen testing and some of the considerations that you need to be on the lookout for if you are to really roll this out in the most smooth way possible. There is still a lot of learning from the Zambia team. And in the next 1 year or so, we hope that you will get back to us and again, share some of those additional strides that you will have made, and also some other countries that may be also taking this direction, so that then the continent can entirely learn from each other. So with those and from us, ASLM, thank you again for joining, and we wish you the best of your afternoon, evening, or morning, depending on where you're joining us from.
Thank you very much.
Thank you, Dr. Sui.